Delighted to be here and to look in the audience and see so many friends. And I want to give a special thank you to the fellows. Dr. Wang has made me aware that you were instrumental in my presence here, and that really is a very flattering gesture, and I'm humbled by your generosity and by your kindness, and it's been a delight to visit with all of you, and I certainly wish you very well in your career development. But it's also a real pleasure to be here because, as Mike pointed out, I have a ton of friends here, a lot of like-minded colleagues, people with whom we've collaborated. I might look in the audience and I see co-authors and co-investigators, and so I have a sense of kindredness, if you will, by being here with you. I wanted to think carefully about the things that I discussed on today's visit because I respect greatly the expertise that exists in your midst. There are those here who understand heart failure at least as well, if not better than me. There are those here that can recite guidelines at least as well, if not better than me. But what I elected to do was to talk about two things, one of which we've already addressed, that may not be the common discussion to have. The first was the discussion earlier today with the fellows that really kind of identified the economic landscape in which we all will be functioning, in which they will be entering. And I hope that for the fellows, that was a very different kind of discussion that was in and of itself provocative and thought-inspiring. What I wanted to do with you, though, is to give you a perspective that I've learned, and I think Magnum has tapped into the same resource that I have, about this entity that we as cardiovascular specialists really use as a backbone for what we do, and that is the clinical practice guidelines. It's pretty evident that we will increasingly be required to be cognizant of these statements. And so what I'd like to do is introduce you to what I think is the beginning of a brand new dimension or a new era. These are my requisite disclosures. I discovered last night that you have this very slick online program where I am to declare everything, so I've done that, and if you want to challenge any of this, it's now online for you. But these are the objectives that I'd like to go through. I'd like to start with a process that identifies what it is that we use to inform clinical practice guidelines, which is the whole process of evidence gathering, and then take you on a short journey about where we've been and address the question of the imperfectness of the current clinical guideline generation process, and then answer a fundamental question about whether or not the clinical practice guidelines, those that I know best, heart failure, do they actually work, and then transition into how we address our uncertainties and where we're going with the future. And I think the information that I've backloaded will be of most interest to many of us. So this is a graphic that a committee on which I serve, the Methodology Committee of the Patient-Centered Outcomes Research Institute, published in the New England Journal of Medicine just last calendar year. And it really articulates an experience that many of us have had in medicine. That is, we've seen the progression of evidence gathering over time. If you start with the 1940s era, this was really the first, believe it or not, iteration of randomized controlled trials addressing in large measure the potential benefit, harm, or lack of benefit for antibiotic therapy, the introduction of kidney dialysis, the introduction of influenza vaccines. In the 1950s, we developed cardiopulmonary resuscitation, kidney transplantation was developed, and then we began to do open heart bypass surgery, and the corresponding research methodology was to look at case control analyses and the introduction of Kaplan-Meier survival curves. In the 1960s, we really got much more in depth with coronary bypass grafting surgery. And as you know, this was the introduction of the heart transplantation era. And then we began with the notion of having to acquire data in observational databases, developing data and safety monitoring boards. By the 1970s, we had introduced intensive care units and coronary angiography, and we were beginning to think about more definite experiences with randomized controlled trials. And by the 1980s, we had thrombolytics for heart attacks. We began to think about propensity scoring, and by the 1990s, coronary stents were developed, triple therapy for HIV. By this time, we began to introduce the language evidence-based medicine, came up with concert statements, and started to understand more about the infrastructure of clinical trials. And in the 2000s, we had the Human Genome Project. ClinicalTrials.gov was birthed, and now we're in the era of genomics, epigenomics, or epigenetics, and we're beginning to look at patient-centered outcomes research. I take you through this journey because I think it's illustrative of where we've been as an entity being medicine, with the original just observational experiences through structured methodologies, the results of which all have been used to both introduce new treatment modalities, but as well to inform clinical practice guidelines. It is interesting that in 2008, as a matter of law in the Medicare Improvement Act, it was articulated that new standards needed to be set for clinical practice, and they needed to interface with the Institute of Medicine. The Institute of Medicine went on to generate a report called Clinical Practice Guidelines We Can Trust. And I think it's interesting to look specifically at this language. Clinical practice guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of the evidence and an assessment of the benefits and harms of alternative care options. That's a pretty powerful statement. And one of the most noteworthy statements here is that of a systematic review. This means something other than, I remember reading a paper once. This means a structured, orderly process to look at a data set and use that to inform these clinical practice guidelines. That report from the IOM went on to articulate that this systematic review would be the foundation. The guidelines would be written by a multidisciplinary panel. It would consider important patient subgroups. It'd be based on a transparent process. It would work to minimize conflicts of interest and biases. It would be logical. It would be logical. It would be logical. That's been an argument about our guidelines for quite some time. And importantly, it would provide ratings of the strength of recommendations and the quality of evidence. So if that is definitional, if that determines what it is that we're doing in the generation of clinical practice guidelines, then it's necessary to do an analysis. So where have we been? This is something that was shared with me by Sid Smith just down the road, a friend of all of ours. And it really looks at the totality of the guideline generation experience within the ACC from the beginning of the guidelines through 2007. It's important to look at the aggregate numbers, 25,000 total days in the generation of these clinical practice guidelines, of which 12,000 were spent in writing the guidelines, another 8,000 in peer review and resolution, another 2,000 in organizational approval process, and then another 2,000 from the Board of Trustees review to publication. If you do this on a per guideline basis, this is exactly what you come up with. It takes over a year to actually write the guideline, another 9 months or less to do the peer review and resolution of peer review, another month for the Board of Trustee process, and then another 2 months to publication. Now I can make this real palpable and tell you what we've just gone through writing the 2013 heart failure guidelines. We started in March of 2011, so it's been a 2-year investment. It literally took us about a year and change to actually write the guideline. We had nearly 800 peer review comments, all of which had to be individually answered with the response sent back to the reviewer. That's been done. And then we've had this 1-month dwell time with the Board of Trustee review process. That's where the guideline sits now. What's different about Board of Trustee to publication is that once we pass this process, the guideline will actually go online and publication will happen 2 months later. So this is exactly the experience we've had for the heart failure guideline. And if nothing else, particularly for the fellows, it lets you know that this process is very deliberate, is very involved, and is a major investment of time and resources, many of which are in-kind resources, to develop the guidelines that we've referred to on a regular basis. Now, one of the other statements from the Institute of Medicine was that there had to be a hierarchy for the guidelines to exist. This hierarchy is the color coding you see here, and over time it has morphed into several different components. So you will remember that going from left to right, this is class of recommendation, and it's a function of benefit versus risk, As you proceed, benefit versus risk becomes more equivalent until you end up with either no benefit, class 3, or harm, class 3. Additionally, there are levels of evidence. And I want you to appreciate that these levels of evidence are quite qualitative. They just have to do with the description of the data sources. Here, multiple randomized controlled clinical trials for level of evidence A, a single randomized trial and observational data for B, and then just consensus opinion for level C. And what's really important is that if you go through this process, you will especially see along the top that there is not just recommended language, but mandated language that we ought to use in writing these guidelines. So we don't say it's a class of recommendation 1 without using the word should be performed, or class 2A, it is reasonable, or class 2B, may be considered. Now you would think that that language is a language we all speak, and that we're comfortable with it, and when you say guidelines, this is what you see. Well, here's the reality. If you look at the ACC AHA approach, if you look at the grade methodology, and I've spent a fair amount of time studying this, the United States Preventive Task Force, we've worked with them as well, the National Heart, Lung, and Blood Institute, and the American College of Physicians, none of these are perfectly aligned. Yet all of these are extant hierarchical schemes that exist in the guideline generation process, which generates some ambiguity, some uncertainness, even confusion about comparing one set of recommendations to the other, and there is no agreed upon common language. But to take this even further, this morning as I was coming over here, I opened up an email and I downloaded an app that's called the Guideline app, and I'm going to go to it here for just a minute so I can give you the exact name of the app. I couldn't believe how timely this was. But it's simply called Guidelines. And this app comes from a place called Guidelines Central. Do you have any idea how many clinical practice guidelines are on this one app that was free for me to download today? Have any idea? So I just went to the treatment guidelines, 1,515 guidelines. It's right here. Sonic can be my witness. It's right here. 1,515 guidelines. Now, just think about this for a moment. If we have this many different hierarchical schemes for the top tier guidelines, if I can be so presumptive, imagine how many different schemes exist in the space. Even beyond that, if you just do a simple arithmetic and say it really does take a year to write the guidelines, you've got a committee of 20 persons and the in-kind contribution is about $200 per day for the investment of time and resources. It's not difficult to get to about $750,000 to $1 million per ACC generated guideline. Do you think the other organizations are making the same investment? Yet everything is called a guideline. I think this is the tension in the space, that a number of things have the imprimatur of a guideline statement, but don't have this infrastructure. So it's incumbent upon us in cardiovascular medicine, since I really do think that us and those at NHLBI especially are the lead animals here, to really be very precise and very Socratic in how we develop these and how we move forward. These data you will know well. It comes from Research Triangle area investigators, UNC and Duke. And to highlight the red arrows to say that even with all of this effort in infrastructure, if you believe that class of recommendation 1 is our strongest statement and level of evidence A represents our best evidence, fewer than 10%, 9.4% of all of the ACC AHA guidelines generated through 2009 qualify that meet this bar for the highest class recommendation with the best level of evidence. To put this in another way, if you look at level of evidence A, I would have you compare the previous iteration of heart failure guidelines where 1/4 of the statements are supported by level of evidence A versus the previous iteration of the valvular heart disease guidelines. 1 out of 320 recommendations are supported by level of evidence A. 1 out of 320, that's 0.3%. And if you change the prism to level of evidence C, and a number of us have unique anxieties about using this level of evidence C, Heart failure, half of the recommendations in the previous guideline, half of the recommendations supported by a level of evidence C. For valvular heart disease, 70% supported by a level of evidence C. The editorialists who accompanied the article published by the investigators from UNC and Duke made the argument that we should dismiss the whole paradigm, that it's baseless, it's not couched in evidence, but this is our current state of the art. What makes this slightly more troublesome was this analysis that was published in the Archives of Internal Medicine that looked at the potential, not necessarily real, but the potential conflicts of interest that were represented by members of guideline writing committees. And I think the area that speaks most to a point of anxiety is to look at the consultant advisory board column and to look at the stock other ownership column. I'm less focused on the percent involvement, and I'm more focused on the fact that none of those columns has a 0. So it tells you that up until recently, there was quite a bit of representation of those with significant engagement with industry sitting on guideline writing committees. Not necessarily a bad thing, but the optics of this are disconcerting for some. So if you look at this intermediate summary I've placed here, the first point is that it's an imperfect process, it's slow, it's expensive, it's lengthy, some would say it's compromised by questions of relationships with industry, and in large measure, a big majority of these statements are non-evidence-based. So the fundamental question is, if this is the case, do these guidelines actually work in any way, shape, or form? So let's look at what we already have to work with in the heart failure space, the 2005 and 2009 guidelines. I don't think I need to set this template up for you because you recognize and you've seen it many times, but it's the summary statement of the classes, that is the stages of heart failure, the prototypical patients, and the most highly regarded therapies for heart failure. And if we deconstruct this to just those therapies shown to change the natural history of disease, we have a relatively short list, and I think everyone in the audience knows what's on this list, and there's a need to dwell on it. But there is a need to dwell on this. Do these clinical practice guidelines actually work? Beginning in 2004, Greg Fonerow and I generated a thought that we would extend the experiences we had already described in the literature about the quality of care for hospitalized heart failure and take it to the outpatient setting. Such had not been done before. We found a willing sponsor that gave us the independence to develop the model, and so we started acquiring data amongst 161 practices of cardiology in this country, 90% in the private or not-for-profit segment, 10% in the academic segment. We had over 16,000 patients. This was coincident with the publication of the 2005 guidelines. I was on that committee, but prohibited from actually suggesting what it was that was necessary for us to do based on what we had deliberated within the guideline writing committee. But nevertheless, the independent group that helped generate these quality measures, including Chris, came up with a set of 7 attributes of quality that were exactly in line with the clinical practice guidelines we eventually generated. Now, what's interesting is that even on the back row where my good friend Sunil is, you can identify, that's a prompt for him just to look up for a moment. You can identify the variability for each of these 7 metrics of quality. So what that tells you is that even amongst cardiology practices that knew we were looking, there were these inconsistencies in how the quality attributes were being applied. And if you do something as simple as looking at the miss rate, for ACE inhibitors, ARB, 22%, for beta blockers, 15%, for aldosterone antagonists, 65%, anticoagulation appropriately for atrial fibrillation, 31%, CRT, 62%, ICD, 50%, and even documenting appropriate education of patients, giving lots of latitude for any field being captured. 40% of the time we fail to document that we simply educated our patients. So the first observation is that even though all of these things are evidence-based and driven by guideline statements, terribly inconsistent application amongst cardiologists, that knew we were doing a quality improvement initiative. So we went on and followed this group of patients longitudinally and published this paper a year and a half ago that was looking at an outcome measure associated with the process measure, the quality of care measure. And we were able to identify that if you were compliant or adherent to at least 5 of these measures, looking at them individually, that in fact there was evidence that over 24 months there was a reduction in the risk for death, the exceptions being aldosterone antagonists and the exception being heart failure education. This calculus was important enough that when we adjusted the data, it turned out that for 6 of the 7, we could prove that separately or individually they were associated with better outcomes, again the exception being the aldosterone antagonists, but with a fairly wide confidence interval. And we were able to further calculate that for every 10% improvement in guideline adherence, there was a 13% reduction in mortality. Now pause with me for a moment and think about the magnitude of that statement. Here's an imperfect process. At least half of the guidelines are based on consensus opinion, inconsistent application of use, nevertheless sufficient veracity in the outcomes vis-a-vis being adherent to the guidelines that you could generate a strong signal, highly statistically significant, of survival just looking at compliance with these individual quality attributes. But what about a different approach, not just looking at them in a singular way, but looking at them in an aggregate way? So we published these data in the inaugural issue of the Journal of the American Heart Association and used a nested case control analysis to really take a look at this. Interestingly, our cases were the patients who died from heart failure, and our controls were the others. And because the database was sufficiently large, we could do a significant amount of matching and use a greedy matching technique, so we had a 1-to-2 ratio. The other thing we did was to construct the model based on the likelihood of how we would treat patients, and we used the beta coefficient with each one of the covariates to understand what generated the most impact on the outcomes for our patients. And what we discovered was the beta blocker alone versus not being on anything but diuretics, 39% reduction over 24 months in the risk of death. Beta blocker plus ACE follows, beta blocker plus ACE, ARB, or ICD follows, so forth and so on. You can see how dramatic the outcomes can be improved over a 24-month period with adherence to evidence-based strategies. And if you just put this in a scale that is very graspable, if you will, ACE or ARB 38%, plus beta blocker 77%, plus device therapy 90%. This is a moment of pause. This reminds me of the literature that Eric has published looking at performance measures in the setting of acute coronary syndrome, this aggregate benefit of doing the right thing for the right patient at the right time that leads to improved clinical outcomes. And this is the first time this has been demonstrated in heart failure, and one of the few times that there's been a point of validation for a clinical practice guideline. So you can actually look at this stair-step approach and see that going from 2 to 3 to 4 to 5 or more therapies, the magnitude of benefit correspondingly increases. So I think we can make an argument that remarkably, despite the imperfectness, the guidelines, at least in the heart failure space, appear to work well. But how do we address our uncertainties? So there's certain things that we are addressing in the new iteration of the heart failure guidelines. Device therapy with CRT, advanced heart failure care, LVADs, quality measures, performance measures, updates on aldosterone antagonist use. We are making a good faith effort to be more explicit in the treatment of heart failure with preserved ejection fraction, but then we have some other things that we're not able to address as well. Surprisingly, dietary sodium intake and then heart failure readmissions. But what I want to share with you is what the Europeans decided to do about those things for which they didn't feel they had a strong enough database. So first, they included different diagnostics than we did, making specific reference to cardiac MR. Next, in terms of treatment, they significantly downclassified the use of hydralazine and isosorbitol nitrate, something that we've helped investigate and believe that it actually is a quite potent adjunct. They have, like us, expanded the use for CRT and for mineralocorticoid antagonists, but where there have been questions, where there was insufficient evidence, what they elected to do was to not comment. Now, this is an interesting strategy. In our environment, our users want us, they want the committee to say, regardless, tell us what you think. They want to get level of evidence C information. The Europeans said, no, we don't have an evidence base for acute heart failure, so we're not going to address it. We don't have an evidence base for sodium restrictions, so we're not going to address it. Telemonitoring, the evidence is conflicted. Functional MR in severe heart failure, surgery may be reasonable, but insufficient evidence base to inform a guideline. So that is how our European colleagues wanted to do this. So let me just show you two examples that we had to wrestle with in our heart failure guideline, just to see where this is. So what about the expanded indication for CRT with regards not to improvement in morbidity, but in mortality? So there are three studies, MADIT CRT, reverse and RAF, all of which purported to study patients with mild to moderate heart failure, and only one, RAF, had this mortality benefit. The rest of the results are all concordant and show a benefit in mild heart failure. We don't disagree with that. But now if you look at the long-term outcomes from the reverse study, a study never powered to show mortality and never powered for longer-term follow-up than 12 months in this country and 24 months in Europe, it turns out that they elected to continue to follow the patients up to 5 years. Those are the data that I want to share with you now in this long-term study that remarkably shows the durability of the reverse remodeling effect with the drop in end-diastolic and systolic volume indices and the durability of the improvement in LVEF. So it does seemingly work in a way that we think improves clinical outcomes. The 5-year mortality was 13.5%, and the mortality morbidity number, including hospitalizations, 28.1%. We know intuitively that those are better numbers than we would expect in natural history of heart failure. But this isn't a population without a control. So the question becomes, are these data sufficient to give us a level of evidence A to support a class of recommendation 1? It requires 2 randomized controlled trials. And that is a deliberation that we have to take. So yes, it produces sustained reverse remodeling and the benefits persist, but no, this was an underpowered study with no long-term comparator, and we're still left with only 1 trial to demonstrate benefit. I can't yet show you what we did with the heart failure guideline, but I can share with you what was done in the device-based therapeutic guideline. And what was determined to do there was to really make no specific comment about the improvement in mortality or morbidity, but rather to just set this color code of green, yellow, and red vis-a-vis the indications for CRT, saying that it is effective without necessarily articulating that that effectiveness is to reduce the risk of death or improve the likelihood of hospitalization, i.e. reduce the number of hospitalizations. A very different approach than we took in heart failure, because in heart failure, we made an effort that for everything that we said was recommended, it was recommended because it will have this effect. For the device-based guidelines, it just simply said, this is recommended because it's beneficial, and it's important, again, for the fellows to see where the red boxes are. For those patients with class 1 symptoms, a non-LBB pattern and a QRS less than 150, not indicated. For NYHA class 2, again, not indicated if QRS is less than 150, non-left bone branch block pattern. And for those that have atrial fibrillation, there's no green box. There are a number of provisos. You can see this in more detail in the device-based therapeutic guidelines, and we have replicated some of this in the heart failure guidelines, so stay tuned. Here's a second case study. I am confident that if I did a poll right now and said, how many of you actively practice sodium restriction in your patients with heart failure? Nobody would dare say they don't. Everybody would say they do. And then if I challenge you to say, where's the evidence that that's the right thing? If you were honest, you would say, I'm not so certain. And so our guidelines, and this is one of the issues that has really driven our guideline task force nuts, is that we have a class of recommendation 1, level of evidence C, that salt restriction is indicated in patients with heart failure. So that means it is recommended. You should do this, and you should do this simply because we say so. Well, in 1922, the Nobel laureate Niels Bohr said, we shall never understand anything until we have found some contradictions. And this model, popularized by Bob Schreier from University of Colorado, made it evident that there are several reservoirs where volume resides. There is the venous capacitance side that includes our capillary system, the heart itself, and effective arterial blood volume. We've never figured out how to measure that, but we know that it encompasses somewhat of our volume capacity, and sodium is distributed across these different compartments, and it sets our volume homeostasis. And so it's been intuitive that if heart failure is a volume problem, sodium management should be inherent in that discussion. But what about the evidence? Well, you can start with these data published in 2011 in the American Journal of Hypertension, a meta-analysis that included one heart failure trial. You can see the relative risk reduction for all-cause mortality and CV mortality for both normotensives and hypertensives was not statistically significant, but in heart failure patients, salt restriction significantly increased all-cause of death. Now, you may say that's an aberration because it was one study, but these data published in September are hard to ignore. 6 randomized controlled trials comparing low sodium 1.8 with normal sodium 2.8. That's not normal sodium in Texas or Louisiana, and I don't think it's normal in Chicago, but that was their argument. Just under 3,000 patients, but this is the worrisome thing. A low sodium diet was associated with increase in all-cause mortality. You see the parameters, increased sudden cardiac death, death due to heart failure, and look at heart failure readmissions, a 2-fold increase. I mean, this is another pause moment. It really calls into question, what is the certainty of our class of recommendation 1 that we should observe a low sodium diet? And beyond that, what's the quality of these 6 randomized controlled trials? Is this just noise? Can this be dismissed? Can we have the conviction to say, regardless of these data, we should be true to our concerns about sodium restriction? And here is a part that's even more troublesome. The American Heart Association, an organization that I love dearly, came out emphatically during my presidency, in fact, in saying that not only should the sodium intake be 3 grams per day for everyone, but for those with cardiovascular disease, we should drive it to 1.5 grams. Were we actually advocating a strategy that would hurt patients? And that is troublesome, and that explains our anxiety about level of evidence C recommendations in the absence of evidence and the potential that we might do harm. So let me be true to my outline that I set up originally and make another, if you will, frame shift and talk about moving forward, anticipating the future. I've had the privilege of being involved in the genesis of comparative effectiveness research under the auspices of the Patient-Centered Outcomes Research Institute. And it really is a way to understand a different way of using observational data. A lot of the impetus for this came from the TARP initiative in 2009, where $1.1 billion was appropriated to spur the development of registries, clinical data networks, electronic data, and outcomes data to better inform the practice of medicine. And the Institute of Medicine was charged with setting up the research priorities for this $1.1 billion that was separated amongst 3 groups. That, if you will, was the beginning, the launching pad for comparative effectiveness research, which has come forward out of the Accountable Care Act as the Patient-Centered Outcomes Research Institute. This is a very provocative approach to research that really opens up some new dimensions. It is based on patient engagement, where patients are helped to have more clarity regarding the choices they face. There's this phenomenon of patient-driven research that is aligning research questions and methods with patient needs and dissemination, providing patients and providers with information for better decisions. I would think that if I did a poll, another poll, of everyone in this room and some of the nation's best clinical investigators in the room, how many times prior to the design of a clinical trial, a randomized controlled trial, did you actually engage the patients you were studying and query them vis-a-vis what questions they wanted you to address? What were their anxieties? What were their needs in heart failure, ACS, in STEMI? And again, if we're very candid, we'd say we've never done that. Never done that. We've assumed that the questions that we find intellectually curious or the opportunities that are presented to us by entrepreneurial entities within the space are sufficient, and that the results that we come up with should be acceptable to all those that are involved, and that may not be the case. We spent at least the first year of PCORI involved in discussions with patient groups, and we were able to distill what their view of research was into these 4 questions. Given my personal characteristics, conditions, and preferences, what should I expect will happen to me? What are my options and what are the benefits and harms of those options? What can I do to improve the outcomes that are most important to me? And how can the healthcare system improve my chances of achieving the outcomes I prefer? So that means that somehow or another we have to be actively involved in patient engagement. This is very, very different and difficult for us because we're very accustomed to counting things and using the results of our counting as sufficient evidence to support the generation of a clinical practice guideline statement. And now we're talking about interacting with people. And so there are 4 dimensions of interacting with people. There's a dimension where we live right now, minimal public involvement, where we literally don't reach out to the patient at all. Our research is driven by our own ideas, and we minimally engage the public in terms of collaboration. Then there's a consultation experience done more avidly in the UK than here, where the public is encouraged to provide their views and to give us the benefit of their experiential knowledge. Then there is the actual collaborative initiative, which nobody does well, where the public is brought into the planning of the research, into the practice of the research, if you will, and into understanding the synthesis of the research. And then the furthest extreme is control, where the public actually drives the research projects, and I'm certain that I don't know how that looks. But I can tell you that what we've come up with in PCORI is a realization that we have to shift from a quantitative research approach to a largely qualitative research approach in order to successfully engage patients. And so there are 2 big buckets, taking this consultative approach and taking the collaborative approach. The consultative approach starts with something as simple as one-on-one and group interviews. We've done a lot of this. It is kind of this nouveau approach of crowdsourcing, getting multiple opinions from many, many people. Observation helps, questionnaires help. The collaborative approach is very provocative. There's an entity, this public-physician partnership, that's known as the James Lynn Alliance, and we've worked with them to understand how we can set up something similar in this country, where using a theory called nominal group theory, you're able to get people in a room and they don't behave like physicians. When you get physicians in the room and you ask the question, there's usually a lead voice that predominates and everybody says, well, I kind of agree with Felker. Yeah, that makes sense. Well, you know, I can only add to what Felker already said. Well, that's kind of the lead voice approach. That's not nominal group theory. Nominal group theory gives each person a finite amount of time to speak, and it looks at the commonality of the messages, weighs those messages, sets those aside, and keeps working through the process until you end up with only disparate views, and then you take those things for which there's most agreement and say that represents kind of the center of where this group of individuals believe the theories are and the questions are most important. And then the one that I particularly like is this notion called patient juries, and again developed in the UK, where you spend a day providing patients an evidence base, giving them the factual information. And then on the second day, you actually deliberate the information. That's the jury in deliberations. And they come up with questions after that, and those questions form the backbone for how the studies are put together. So what that really means is that as we go forward, we will have to think about this brand new dimension, which we are spending a lot of money on, and for which we have a lot of patients now independently and separately engaged. But we have to be willing, as those persons who write clinical practice guidelines, to use that kind of patient-centered research and the outcome from that research in the generation of our guidelines. That is not just a dream. That now is a commitment made clear by this paper published online in December of 2012 and now in print in January of 2013. And this is the result of a task force on which a number of us in the audience participated and was led by Alice Jacobs as a former chair of the ACC-AHA Guideline Writing Committee task force. And I think it's worth your time to see how this process is going to change over time. So There are several new domains. I've got 4 of them listed here, but the very first one is incorporating patient representation. There will be patient representation on guideline writing committees going forward. Developing systematic reviews, not just recall of, well, I remember this paper I read, or I did a Google search, or I did a PubMed search, but an actual systematic review that gets into gray literature, gets into unpublished literature, to really understand what's the information space for the questions being addressed. New standards for assessing the quality of evidence, not just the number of papers, but is this really a good paper? Does it really meet the bar? And is there a standard template to judge this? And then standardizing the synthesis of evidence. So this notion of a patient being involved is a little bit troublesome to everyone, because the patient member will be a full voting member of the guideline. Talk about bias. You expect the patient to have bias based on their experiences. They'll assist in developing the clinical questions, assessing the quality of life data, and importantly, peer review will be very different now. It will be expanded to include more stakeholders and members of the public. Frankly, I'm glad this is happening since we generated the heart failure guidelines, because each of those 800 peer review comments I personally had to answer. And if I had to answer stakeholders and patients, that would have been a long process. But we've got to figure out the right way to do this. The one reason I don't have that much anxiety about this is that the FDA has incorporated patient representation, non-voting, on its panels, and they've actually been quite sophisticated and have helped the process, I think, in a major way. The systematic review part is also very interesting, and I will share with you yet another experience from writing the heart failure guidelines. We spent the first 6 to 7 months just in generating evidence tables that appear as appendices when the final document comes out. So we were each charged with the domain of heart failure, and were tasked to go out and find as much information as we could, and using our own mental framework, adjudicate that information, and then create these evidence tables. It was an arduous task, a task which will no longer be the responsibility of the committee, because something called an ERC will now be utilized to generate ACC guideline statements, a defined evidence review committee that importantly will not have content expertise membership on the committee. It will just be methodologists and evidence review experts, so that there's no bias whatsoever. It really will be a very plain and straightforward way of trying to understand what are the attributes of the papers and are they informative. And it will be a standard format to be used that involves the P-code system, population, intervention, comparator, outcomes, timing, and setting. And the protocols used to do the systematic reviews will likewise be subjected to peer review. This is already fairly far along in development and may even be ready for public disclosure, but a tool has been developed to exercise a qualitative assessment to look at the evidence used to generate clinical practice guidelines. So it no longer will be just simply a randomized controlled trial, but what trial was that? Was it a trial where there was independence for the investigators, where there was freedom and complete access to the data? What was the involvement of the sponsor? The 3 domains will be freedom from bias, relevance, and fidelity of implementation. And studies will be judged as follows: fatally flawed, low, intermediate, and high quality. This will be a very different space than we have ever had in the ACC regarding generation of clinical practice guidelines. In terms of synthesizing the evidence, we will depend more on summary and evidence tables. If there is not an available review, one will be commissioned. That will come at some cost. We're still wrestling with how we'll do that. A meta-analysis, where not available, will be commissioned. We've already got a paper coming out in circulation now where we've done a pilot project addressing the treatment of unprotected left main medical therapy versus PCI, where we did a high-quality network meta-analysis and applied Bayesian methodology there. And then the systematic reviews themselves and the meta-analyses that have been used will be published to not supplant, but to support the clinical practice guidelines. So this is really where I tried to take you this afternoon. I wanted to introduce you to what I think are dynamic changes that are happening in this very important tool we use in everyday practice, that is clinical practice guidelines. I wanted to take you through the history of how we've gathered evidence from the 1940s going forward, and then introduce you to the state-of-the-art as it exists for our cardiovascular guidelines under the banner of the ACC and the AHA, go through that hierarchical scheme, show you the noise in the space, the different schemes, and the incredible number of guidelines that exist across the entire space, demonstrate that despite the imperfectness, they seem to work, but then introduce to you some of our tensions, the uncertainties we have about certain things, the necessity to understand how we should deliberate new evidence and new evidence sources, and then importantly to realize that in real time as we speak, the current newly initiated guidelines are going forward with much of what I already shared with you, patient representation, using evidence review committees, and commissioning systematic reviews. This is a very different way of generating clinical practice guidelines. But there are some concerns that should be expressed. First of all, we have already swallowed the bitter pill of divulging all of our relationships. Will patients and their stakeholders do the same thing? How do you maintain confidentiality if you involve the public in the peer review process? For these evidence review committees, the generation of systematic reviews and commission meta-analyses, these will come at a cost. Who will pay for those? Will there be user fees? Can we strike a level of comfort with comparative effectiveness research, observational data, and say it is sufficient in and of itself to generate a class of recommendation 1 for what we do? And then considering the time investment, Mike asked me earlier this afternoon, how many hours do I think I invested in the generation of the heart failure guidelines? And I very quickly said hundreds. Can we continue the volunteer status for writing committee members given all the other tensions in the contemporary workspace? And what about the type and quality of investigations that are being done? Do we need to go backwards a step and initiate different kinds of clinical trials that answer very precise questions? I think that the Cardiothoracic Clinical Trials Network, the Heart Failure Clinical Trials Network are both good examples of finding ways to do that. And then the most important question, is this change really necessary? The guiding principles set forward by the Institute of Medicine, are they really that important? Are we changing something that already works reasonably well, or should we go forward understanding that the imperfectness of our guidelines will compromise our ability to deliver quality care? So I hope that some of this has been informative, particularly in terms of identifying the new directions. But I do think that those of us that have been involved in the writing guidelines have a very different respect for what it entails and for how we should use the guidelines. And as you're using the guidelines, think about this process and understand that it's very fluid, very dynamic, but it's also very necessary because it really governs how we should practice medicine going forward, especially as we go from a volume-based environment to a quality-based environment. Thank you very much. I'd be happy to take your questions.